Hello.
Hi, Kevin.
Hello, hi.
Hello, I can hear you loud and clear.
Great, great. So, good afternoon, Council. And right about now, it is 2:12 p.m. in Nairobi, Kenya. I'd like to welcome all of you to our session today. Our presenter for the day is Dr. Kenneth Ngure. I'll allow him to introduce himself further. And our session today circles around last year's IAS 2017 conference. And Dr. Ngure will be speaking to us on a couple of lessons from the HIV prevention as well as the implementation science tracks of that particular conference. So, Dr. Ngure, I could hear you loud and clear. Please proceed, introduce yourself, and then take it away.
Thank you, Kevin. Good afternoon, everyone. I guess everybody is in the almost a similar time zone. My name is Kenneth Ngure, as you've heard. I'm a GC member representing the African region in the International AIDS Society. I'm also faculty at the Department of Community Health in Jomo Kenyatta University of Agriculture and Technology. So this afternoon, I'll focus on two tracks that were presented at the recent IAS conference in Paris. There are 4 tracks, but in the interest of time, even condensing these 2 tracks into 1 hour was quite took some time, considering that we'll also need to allow time for discussion. So I'll start on with giving highlights of on the prevention science track. Remember, this was so many presentations, but we have selected just a few just to focus on today's that we think are key. And specifically, as an overview, I'll focus on HIV self-testing, which is a key component of testing, and then treatment as prevention. I'll present 2 studies there, and then I'll go on to talk about oral PrEP from rollout, on-demand regimens, and on-demand versus daily and plus pills, a study known as plus pills. And then I'll move on to new PrEP agents. And specifically for this presentation, I'll focus on the dapivirine ring and injectable cabotegravir. So on HIV self-testing, there are numerous studies that have been conducted in sub-Saharan Africa and that were presented in IAS. And these studies showed that the estimated self-testing market in Africa is large, and there are about 3 to 5 million users of tests distributed through community channels, and 11 to 15 million users have invested in distribution and have been able to access these kits through pharmacy and health care facilities. And secondary distribution to male partners by women attending ANC clinic has been evaluated in studies in Uganda and also other studies currently happening in Kenya. And also self-testing is feasible and acceptable for female sex workers in Zambia and Zimbabwe. And leakage may be lower than in facility-based testing. So one of the key challenge of HIV self-testing has been the issue of linkage to care. And there has been a theoretical concern of increase in intimate partner violence, but thankfully most of the studies have not reported any concern with intimate partner violence. And these studies on the African market have been done by a group known as the STAR, and it's conducting some of the largest studies of HIV self-testing. And just to also add the reasons why female sex workers may particularly accept HIV self-testing, they have reported in studies that HIV self-testing offers them privacy, convenience, and so because sometimes their schedules may not fit within the regular opening of clinic times. Then we move across the Atlantic and go to the US, and this is known as ESTAM, and this study is an online provision of self-test to men who have sex with men, and some who have not been previously tested, and This study showed that there were no differences in sexual behavior between the two groups, and that implementing internet-based HIV screening programs with free HIV self-testing increased HIV testing and diagnosis among men, including those who had not previously accessed traditional HIV testing services. We change gears a bit and come to treatment as prevention. I know also currently in Kenya we are, and there is convincing evidence that expanding HIV treatment coverage reduces new HIV infection and across the population. And this was a study done in Swaziland, which showed the incidence reduction from 2.48 to 1.39. This is a huge reduction when you look at this at the population level. And as Reader Gail Baker said, this study shows that our efforts can pay off and is a proof of concept. And just to appreciate the statistics, that Swaziland is a very small country compared to some of other African countries, including Kenya, and with a population of 1.5 million. And that one of the things that was also observed is that there was a challenge in some of the younger population. There was less progress in the younger population in terms of reduction of incidence. So there's still some work to be done to the younger populations. Then there's this other study. This study was presented by someone known as Babington. And this study, known as Opposites Attract, was a prospective data or assessed prospective data association of HIV transmission and undetectable viral load in homosexual male HIV serodiscordant couples. And the reason of the justification for this study is that there is very little data on this issue of HIV transmission when there's undetectable viral load among the MSM population. And this study was done in Rio de Janeiro, Bangkok, and Australia. And the conclusions were there was no linked HIV transmissions in close to 17,000 sexual acts, providing strong support for hypothesis that undetectable viral load prevents HIV transmission in homosexual men. I'm sure we are all aware of all the multiple studies that have been done in heterosexual population. So this study was novel in terms of that it was presenting data from MSM. One second, I think I've lost something. Okay, so we move now to rollout of PrEP. And Sheena McCormack of the University College London gave a plenary presentation on PrEP. And the key points were that PrEP is being effectively scaled up in most countries where the research was conducted. These are US, France, Australia, and I would put in capital letters Kenya. We're having a lot of scale-up projects happening in Kenya. And most of this has been achieved without government support through community and online mobilization. Online mobilization is usually very common in the US. And it is important. One of the key lessons we need to take home from her plenary presentation, it is important to focus on what consumer wants. And this is as seen in the field of contraception and where choice is important. But there's an urgent need to scale up PrEP in implementation in at-risk population. That way you are able to give power to the people so that people can be able to choose prevention options themselves. And I'm sure in the next few meetings, you'll be able to get some updates from the Kenyan scale-up projects. Then there was the on-demand regimen, and this was shown in a study known as IPAGE a couple of years ago. But there was a remaining question as to whether on-demand regimen would be effective among a subset of men who had infrequent sex, as a median frequency in the hyper-gay population was that when people took pills, was approximately 4 pills per day, per week, 4 or more pills per week, translating to around that number of sexual contact. And the data from this study shows that on-demand PrEP with Truvada, that is TDF-FTC, remains highly effective in MSM having infrequent sexual intercourse. There was also a follow-up qualitative study known as AMPrep, and this was conducted in Amsterdam, where participants could choose between on-demand or daily regimen. And some of the reasons that are shown here, and the conclusion that we get from this specific study was that given the choice between between daily and on-demand PrEP, participants appreciated having that choice, so that this can allow as their individual circumstances evolve. There are times that daily PrEP would work for them, and there are times that on-demand PrEP would work for this population. And the reasons for the daily PrEP are actually shown there. And then some of the reasons for event-driven, and for example, those who have challenges in daily adherence, where sex is planned, then infrequent low or infrequent HIV risk. And some of them were also concerned about toxicity. Then we move on to another study on oral PrEP known as plus pills. And this study, we are aware that the incidence of HIV in adolescent boys aged 15 to 19 is 0.7 in South Africa, whereas the incidence in girls of similar age is 5.6. And then when you move to the age of 20 to 24, the HIV incidence of men is 5.1 and 17.4 among women, which is almost 3 times the incidence of that of men. And data from this study that was presented and many other demonstration projects support the indication of providing PrEP to adolescents. And what we are able to learn from this study is that this study, participants, South African adolescents, need to access PrEP and to provide protection, especially for the adolescent girls. And there may be concerns on side effects, but whatever was observed in this cohort was minimal. There were minimal side effects. And then we change gears and move to the dapivirine ring. The dapivirine ring, there are studies, 2 African studies. One showed that the Aspire ring that was effective, and one of the studies showed that the efficacy was there, but the challenge with the 2 studies was that there was no efficacy shown for the population that was less than 21 years. And this study now that is presented here by Sharon Hiria was that there was good adherence among this population. And remember, adherence is not only reported adherence. For this population, 87% had detectable drug in blood samples, which is very, very high. And then 95% of the rings had depleted drug levels. And 95% of the young women said it was easy to use the ring. This is quite reassuring, because in the African population, there was no effect among those aged under 21. And the issue was of the reason why there was no efficacy was because of lack of use. When they looked at the drug levels of the returned rings, showed that the rings were not being used by women who are less than the age of 21. But this population of the US women, even younger women, it shows that our younger women are able to use. So maybe we just need to craft our adherence messages. And specifically, this study was actually not by Sharon Hillier, was by Kate Bunge. And now, then we move to the next study on the pivoting ring. And this specific study, again, shows that there was going to look at the issue of bacterial vaginosis. The reason that Sharon Hillier was looking at bacterial vaginosis is because bacterial vaginosis has been associated with the lower efficacy of tenofovir gel in a study known as Caprisa 004 that was done in South Africa, and results were presented in 2010. So there was need to look at whether the pivoting ring was affected by an abnormal vaginal microbiota. And in contrast to tenofovir, genital and plasma concentration of the pivoting were not impacted by increasing concentrations of vaginal bacteria associated with bacterial vaginosis. But there is still a need for future studies and additional studies to look whether this is replicated in other studies. Again, we change gears and move to the injectable cabotegravir. As you have seen from the studies of oral PrEP and also the studies of the ring, adherence has been a challenge. Oral PrEP, the current indication is daily pill. For the ring is a monthly ring that is changeable every month. But even for that, there has been challenges of adherence among African young women. So there is a need for injectable, and there are several studies that are looking at the injectable. And one of them is known as cabotegravir, or abbreviated as CAB, is a novel strata transfer integrase inhibitor available as a long-acting nanosuspension under development for HIV prevention. And this study looked at had 199 participants at low risk of HIV, and they were assigned to 3:1, that is to placebo. One of the cohort had 800 milligrams given every 12 weeks. The other had 600 milligrams given every 8 weeks. But one study also in the US known as ECRE showed that 800 milligrams given every 12 weeks did not meet target drug levels. One thing that is important to note from this RA study is that injection site reactions were frequent, but generally mild. There were also headaches that were reported, and about 8% of the participants withdrew due to these side effects. But the take-home message is that CAB is well tolerated among low-risk HIV and infected men and women, and that the pharmacokinetics support development of CAB for HIV prevention using 600 milligrams intramuscular every 8 weeks with a 4-week loading dose for all sexes. Remember, the loading dose is just to check for adverse events, because once you get an injection and you get an adverse event, then you're not able to pull the drug out as fast. So the highlights from the prevention track are: one, that Swaziland demonstrates that the theory of treatment as prevention works in practice and at population level, and that data support a wide range of PrEP options, both as agents and dosing schedules, and that self-testing helps individuals who do not engage with other testing services to learn about their HIV status, including key populations such as MSM and female sex workers. There are challenges, especially challenges of engaging younger people and men in HIV testing and treatment cascades, and also scaling of PrEP is not available in many countries. So there is a gap there. As you can see even from the slide, Kenya was not picked up as one of the countries that is scaling up PrEP. So there is need to scale up PrEP in many countries in Africa also. So we will change gears now and move to the implementation science track. In summary, we are going to look at the differentiated service delivery model. Starting with why do we do differentiated service delivery? We look at pediatric services, implementation challenges, then integrated services. And then we move on to costs and funding and highlight on the 1990 strategy and US funding decisions. Then we'll also move to economic incentives and also talk about stigma. So why do we do differentiated service delivery? Why is there a need for service delivery? One is that it is a client-centered approach that simplifies and adapts HIV services and is able to tailor the recipients to recipients' needs and location, and looks at all other factors so that the service delivery caters for individual needs. And some of the components for differentiated service delivery include multi-month prescribing so that people are able to get multiple doses. And for those who have less complex needs, they can take several months at a time before coming. And even as we think about this differentiated service delivery for treatment, we should also be thinking that this may also work for HIV prevention. And we also know that monthly clinics can be difficult for patients, including transport time away from work, education. So if you are able then to be able to have care provided according to your needs, then it's going to work well on both clients and also on service providers. So if you have less workload, then you're able to provide better quality care to participants. And then as we continue doing studies on differentiated service delivery, we should focus on adapting differentiated service delivery to populations. For example, for men who have poor engagement with services, then we could have services tailored to men. We could also have services tailored to different gender depending on their specific needs. And then we could also look at models. As the models keep evolving, we need to keep on changing the models so that they're able to meet client evolving needs. Then as we move on to the pediatric services, there's limited data on multi-month prescribing for children and adolescents. Remember that challenges in adherence and keeping to appointments also affect adolescents, and adolescents will also benefit. For example, those who are in school will benefit from maybe less stringent clinic schedules that adapt to their school needs. And there are studies that were done in several centers in Botswana, and there was the reported lower rate of loss of follow-up among the multi-month prescribing. So those who got longer doses were able to adhere to their study visits. And so this specific study that was done in 6 African countries provides reassurance that for patients aged 0 to 19 who are clinically stable and ART adherence can do well with reduced clinic visits via multiple doses, multi-month doses, and the consequent reduction on visits yield additional benefits by decreasing the burden on health systems and patient time. Then we come to the next slide on implementation challenges. And this is what was done in a study that was done in Malawi. And one of the things that we know that this study surveyed about 75,000 people in 30 clinics, and 86% of patients were eligible for multi-month prescribing. That is about 6 months ART, if they had been adherent, and that the data was collected from That purpose we selected ART facilities in 2016, and the data was and the results were weighted by facility. And what we learned from that study is that many clinics are adopting this multi-month prescribing, and though it's not happening according to the to what is outlined, there is need for improvement on health provider mentorship to align this strategy with the differentiated care model of Malawi. So there is a challenge for this kind of multi-month prescribing, and there are quite some of those challenges that have been outlined on that specific slide. Then, what about integrated delivery of services? So one of the key points to note from this specific study is that differentiated service delivery must address key populations such as people who inject drugs. Service implementation for PID needs to leverage effective integration of client service strategies addressing HIV, drugs, and mental health. And what we learned from this study specifically is that there was higher virus suppression when ART was dispensed in outpatient, but no significant difference concerning daily or monthly provision. Now we change gears again and move to the 1990 strategy. One of the key points to note of this strategy is that unaffordable drug prices are a major barrier to achieving the 1990 goals, and large increases in treatment coverage will require medicine prices to be cut. And countries and donors should aim for a new 1990 target on HIV, biohepatitis, TB. So we need to move even to other drugs as we think about these strategies. And this strategy, the estimated, we also need to take account of raw materials, manufacturing, and need to keep on advocating for lowering of prices, especially for drugs, and need to always keep looking for innovative strategies to push for this new strategy, whether it's testing, whether it's initiation and virus suppression, because some of these are mainly affected by the cost of drugs, and these cost of drugs have been outlined here, and there is a need also to move for drugs that have patents that have expired, so that they can move on to generics, which would be cheaper and will be able to make more people access these drugs. Then we move on to talk about US funding decisions. We can't talk about HIV without mentioning about the US funding decision. And the United States is the largest government donor to HIV research, contributing 66.4% of the global bilateral and multilateral funding in 2015. And this was a study done by Kaiser Foundation. And it's good also to remember that 18 countries in sub-Saharan Africa account for 80% of the HIV burden. And counterfactual studies show that if HIV had not provided funding since 2000 to the Global Fund, and the Global Fund had not been created, there would have been approximately 4 million more infections by 2016. And 5 million additional deaths. So this funding from the US is quite helpful, and it is important to keep advocating for this funding that from the US government, and that this study shows that this funding, if continues, can shrink the mantle and reverse. If the US stops, it can reverse the gains that have been done, and we know there have been threats of this So there's need to continue maintaining the momentum. Otherwise, then they would have to we undo all the benefits that have been gained so far. Then there was a talk given by Esther Duflo, who spoke in the opening session on the importance of social science to HIV prevention and the need for including economic incentives, and that economic incentives are estimated and they could boost engagement into services. So there is need to keep on looking at how economic incentives can be used in these services to boost uptake of services and continuation, especially in sub-Saharan Africa. Then there's a study that was done in Mexico, and this study was related again to economic incentives in Latin America. And this study showed that male sex workers in Mexico who had low engagement with health services due to pressing needs, when presented with economic incentives lowered barriers to engagement with care. And we should always remember that the definition of incentive should not be limited to economic support, but anything that helps economically disadvantaged overcome their daily burdens and struggle. And we know, of course, there are many studies that are being done in our African context on economic incentives to reduce HIV and keep people engaged in care, but most of those are still under trial in specific studies. Then we come next to, again, on couple testing, economic incentives. And in this study, cluster randomized trial that was conducted in Zimbabwe, it used economic incentives to encourage participation for couple counseling and testing in 68 rural communities. And this study showed that in addition to increasing HIV testing and counseling, non-financial incentives were an innovative strategy to increase uptake of couples testing, and was highly affordable and highly cost-effective. And especially considering this study was done in these countries and which had very low levels of couple counseling and testing. Zimbabwe, for example, had 18%, South Africa had 5%, 15% in Mozambique, 2% in Swaziland, 24% in Zambia. So there is a need to think outside the box and work on economic incentives to boost this level of testing among couples. Then one of the big key challenges in healthcare has been stigma, keeping people engaged. And I'm sure most of us are also familiar with the issues of stigma that keep people away from, for example, HIV clinics. And we know that it negatively impacts engagement in care and retention in healthcare settings. And there has been a lot of studies, many studies even in the Kenyan setting, that are trying to measure stigma and its effect on retention to care. And there is need for better feedback to communities and care providers so that we are able to work on this stigma to reduce the negative or adverse effect that stigma has on the healthcare settings. Then there were still more studies on stigma, and one of them was also again a study that was a prospective cohort among MSM and FSWs, that's female sex workers. And this study is still ongoing, but there is some interim data of up to 15 months that are showing large reduction in anticipated healthcare stigma, and then some reductions in experienced healthcare stigma and low uptake of ART in HIV positive MSM, and the results reinforce the need for stigma mitigation interventions to be combined with HIV prevention and treatment interventions for key populations. And as we think about these issues of stigma for the specific studies that were reported here, it's always also important to remember that stigma could also affect or negatively influence uptake of HIV prevention interventions like PrEP. And for those who are scaling up PrEP, are already hearing that some participants may have issues going to a HIV clinic to access their PrEP. So stigma is also a key issue, and that's why there is a need for providing stigma-free services. And there are studies that have been done, and the specific study here was presented by a social worker from Botswana who reported that the legal environment is hostile to sex workers and discourages female sex workers from accessing healthcare services. And there are several items outlined there. One of them for sex workers is to accept each sex worker as a human being. And I'm sure this would also apply for other key populations. And do not unnecessarily ask intrusive questions. Respect confidentiality when counseling. Assess all persons' needs and make referrals for healthcare issues. Then sensitize other professionals to female sex workers' needs and be creative to overcome barriers, e.g. ensure women get ID cards so that they can access ALT, get trained on emergency ALT prescription. And so there is a need to use this kind of services to increase uptake for female sex workers and other key population. And this presentation was from Botswana. And now summarize from this track, the take-home messages is that the client-centered approach of differentiated service delivery is more responsive to the needs of different groups of patients and may boost their engagement with care. Economic incentives can help engagement with existing services and technologies, but there are challenges. One of the challenges is less commitment to the global HIV response from the largest donor, that is the US. Stigma against key populations in healthcare settings remains an important barrier to access care, and attention needs to be given to appropriate implementation of differentiated service delivery models. I want to end with a quote from Linda Gilbecker, which says the largest and most important donor of HIV response has threatened devastating cuts to funding for research and treatment program. Draconian cuts to HIV funding is a catastrophe we cannot afford to see happen. So I thank you, and I'm ready to take a few questions. And I can see some of them have been written here.
So Dr. Ngure, maybe just before you take the questions I see listed down there, just to add a bit of context for the people who may have joined this session a bit late. What you see right now is the highlights from the first half of Dr. Ngure's presentation, which was leaning more towards the HIV prevention track of the IAS 2017 conference. And you can see from that track, the promising developments were that Swaziland demonstrates that the theory of treatment as prevention works in practice at a population level. Number two, data to support a wider range of PrEP options, both agents and dosing schedule is available. Third, you can see that self-testing helps individuals who do not engage with other testing services to learn their HIV status. And from the first half, the challenges seen were that engaging younger people and men with HIV testing services and the treatment cascade is needed. And then we also need to scale up PrEP in the many countries where it is not currently available. So Dr. Ngure, you can proceed to take the few questions that I see listed there.
All right, I think I can see one from maybe Martin. Martin is saying about injectable was well tolerated among, was just curious, what was the study inclusion criteria? I believe PrEP is meant for high risk and continuous exposure. Thank you for that question, Martin. Remember, these studies, usually studies go through phases. There is a phase 1, phase 2, and phase 3. And when you're looking at new interventions, you usually start with looking at safety. And safety, for example, in these studies were conducted in what you call a phase 2A. And a phase 2A, you're just looking at whether the drug is safe. So you don't need people who are at high risk. You just want to see, first of all, how well the drug is tolerated and what the drug does to the body and what the body does to the drug. So basically, that's what you're interested in at that phase. So you just want people who are at low risk because you have not even gone to look at efficacy, whether the product works. At this point, you don't know whether the product works to reduce HIV acquisition. So you actually want to have a product tested for safety, then you move to the next levels. So I'm sure when it goes now to phase 3, where you'll be looking at whether the product reduces the risk of HIV acquisition, you'll definitely look for people at higher risk of HIV. Then, Maureen, is it wrong to use multi-dosing to reduce the workload and facility? It's not, but we need to find out how well it works, because I'm sure for some of the clinics, it's taken up very well where you're getting multiple doses so that you end up coming to the clinic every 6 months instead of 3 months. So then that would be a key strategy for reducing the workload. And we always want to think of this differentiated service delivery using this strategy. Then, what is the role of behavioral science in PrEP adherence? Do you have models tested out there? Martin, that's a very good question, because most of the work that I do around behavioral science. There are many models, and I would want you to look at a study done by Ariane. I don't know whether I can type. There's a study done by Ariane, and there are many other studies. So if maybe I could give you my email, I could send you many models, including one done by Rivet. Rivet is RVET, and then RIVET, and then there's a study done by Ariane Van Straten. Ariane is ARIANE. So you could be able to look at those studies, and then. Yes. So one of the models is by Rivet Amico, and the other one is Straten. Look for those models. Any other question? Daniel Kimani is asking about whether the slides will be available. I think NAC can make the slides available. They are not patented, so they could be shared.
Yes, Daniel, we can definitely share the slides with you. And I think Dr. Ngure just gave consent to that. So if you leave your email address in the chat box, I can be able to forward the slides for the presentation to you. Gladys Waruguru, you said, I hope we can do more of these forums. Yes, we definitely have a few more of these forums lined up, and the same way you received an invitation to this one, we'll definitely let you know when we have our next forum. So just like Daniel or Martin, if you need the slides emailed to you, kindly leave your email address in the chat box, and I'll be able to forward the slides to you. Any further questions or comments are also welcome before we close the session.
So in summary, I think in the field of PrEP, there are quite a number of activities happening. And the reason we are going to injectable is because the oral has had some challenges in terms of data adherence. And eventually we hope to see a future where we'll have as many options as we have for family planning. As we think about family planning, we have injectables, we have orals, we have implants. So oral PrEP is only first generation. We will have other methods of HIV prevention, which will be injectable. We may even in future have films, implants. The ring is almost now going through registration to know whether it can be available for other in the open market for use.
So if there are no further questions, I'd like to release Dr. Ngure, because we'd scheduled a session for about an hour. I can see people are providing their email addresses. I will definitely be sending an email with the slides. Dr. Ngure, thank you very much for pretty much doing a recap of the presentations that were done at the IAS 2017, and particularly leaning towards HIV prevention and implementation science. Thank you very much for the session.
It was my pleasure.
Great. And to all our participants for the day, thank you very much for attending this forum. We will be having more forums. We'll be having one that will highlight the ICASA conference that was just completed. So you will receive an email invitation to the same, and we hope to see you in our next sessions. So thank you very much. I'll leave the session open for a few more minutes just in case more people are trying to type in their email addresses. Thank you. Do have a great day.